welcome to another insightful episode of MedSynapse podcast series. And today we're diving deep into one of the most critical and life-saving procedures in hematology, which is bone marrow transplantation. And joining us to guide through this is a distinguished expert in this field, who is Dr. Malini Garg, a renowned hematologist and hemato-oncologist with years of experience treating complex blood disorders and cancers through cutting-edge therapies, which includes bone marrow transplants. Dr. Malini has been at the forefront of breakthrough treatments, helping countless patients with both malignant and non-malignant conditions. And today we're excited to learn from her expertise as we explore the evolution of bone marrow transplants, the impact of innovative therapies like CAR T cells, and the future of this life-saving procedures. So, welcome, doctor, and thank you so much for being here.
Thank you so much. Thank you for the kind introduction.
Thank you, doctor. Now, let's start with the basics for our viewers. So, could you briefly describe the different types of bone marrow transplants and the key factors that guide us the choice of one over the other in clinical practice?
So, bone marrow transplant is a kind of therapy which has broadly two types of transplant. We have autologous stem cell transplant and allogenic stem cell transplant. So, autologous stem cell transplant, we do not need a donor. So, I'll be explaining in a very common terms so that viewers can understand. So, in autologous stem cell transplant, a patient is given a high dose chemotherapy, and before that chemotherapy, the stem cells are mobilized, the stem cells are collected, and after that chemotherapy, the same stem cells which are collected from the patient, they are transfused to the same patient. So in autologous stem cell transplant, it is actually a transplant from the same patient to the patient. We do not need a donor. Basically, if we see, it is a kind of high dose chemotherapy followed by stem cell rescue. Usually, when we give very high dose chemotherapy, the bone marrow is completely ablated. The cells, they are not able to recover by themselves. So what we do is, we beforehand only collect the stem cells, and then we proceed ahead with high dose chemotherapy, and those collected stem cells are then given back to the patient. So this briefly comprises of autologous stem cell transplant. Then second one comes allogenic stem cell transplant. Allogenic stem cell transplant usually needs a donor. So the donor can be a matched sibling donor or a matched related donor, can be a haploidentical donor, can be a matched unrelated donor. A donor is the one with whom a HLA typing is done. And if we find that yes, there is a match or there is a haplo match, or maybe it's an unrelated donor but there is a match, we proceed ahead with transplant, in which the donor stem cells are collected, the patient is given high dose chemotherapy, and then the donor stem cells are being transfused to the patient. So here we learn that we have two types of transplant: autologous stem cell transplant and allogenic stem cell transplant. The type of complications, the cost involved, the hospital stay, and post transplant care, everything is dependent on which type of transplant we proceed ahead. Even the indications of both the type of transplants are very much different.
I think that was a fantastic breakdown, but also I suppose the choice depends on a careful balance between the risk and benefit for each individual, right?
So the choice between whether we have to go for autologous or allogenic transplant depends upon the disease, the indications. So basically, autologous stem cell transplant is indicated for, multiple myeloma. Then we have relapsed refractory lymphomas, even some solid cancers like Ewing sarcomas, germ cell tumors. Autologous stem cell transplant is being done. Neuroblastomas we have, and allogenic stem cell transplant. Actually, the indications are different. The indications are we have acute leukemias. In acute myeloid leukemia, high risk upfront we are going. In intermediate also upfront we are going. Then we have relapsed AML, relapsed acute lymphoblastic leukemias, and etc. etc. The list goes on and on and on. For aplastic anemia, for thalassemias, for all we have we go for allogenic stem cell transplant. Now, you asked about the risk and benefit ratio. Yes. So when once we have decided that which transplant we have to choose depending upon the disease condition, then whether we have to go for the transplant or not, apart from other factors which we look, yes, we definitely look at the risk and benefit from that. If a patient is, basically, I can just explain in that terms. If a patient is of 70 years of age, the risk of transplant, the transplant related mortality is going to be very high compared to the benefit the patient will receive in that case. So we do not proceed ahead with the transplant in that particular case. Suppose, like we have to look at the type of benefit, the survival benefit the patient will get with the transplant, and the risk of mortality associated with it. We have to look at the condition of the patient. So all the factors together, we have to look. We have to, rightly said by you, we have to look at the risk and benefit, and then we have to proceed ahead with the transplant.
Thank you for that explanation. Now, speaking of cases only, which hematologic malignancy or non-malignant conditions are currently considered the most appropriate candidates for bone marrow transplant, and how has this evolved over the recent years, if you could tell us?
So if we look at the various conditions, as I told before also, so if we talk about allogenic stem cell transplant, we look for all the relapsed leukemias, relapsed acute myeloid leukemia, relapsed acute lymphoblastic leukemias. So directly we go ahead with transplant. If we look at the upfront conditions like acute myeloid leukemia, intermediate risk and high risk, we go with transplant. There is a controversy that for Ph positive ALL also we go ahead with transplant. A patient who is in aplastic anemia less than 40 years of age, directly we go ahead with transplant. Then thalassemia patients less than 7 years of age, yes, they should be considered for transplant. We have SCIDs patients, they also should be considered for transplant. So these are indications of allogenic stem cell transplant. But we also have to look at the patient condition at that time, the comorbidities present with the patient, and then we consider them, okay, we can go ahead with a transplant. If we look at the autologous stem cell transplant, then multiple myeloma, the autologous stem cell transplant definitely gives a PFS benefit. So we go ahead with autologous stem cell transplant. Now, if you say how it has evolved over the times, so the evolution over the times are the conditions for which we can go ahead with transplant and we are getting a benefit is, the awareness of it is increasing over the time. The transplant centers in the country are increasing over the time. Earlier, for the indications are so many, but we can say that less than 5% of the patients who were actually eligible for transplant or who were the candidates for transplant were able to get transplant earlier. But now this data is increasing over and over the time. Now, so we can say that the complications related to the transplant. So research which is going on, like we have FMTs for, even steroid refractory GVHD, which is coming into the play, and other things like haplotransplant, which has also evolved over the time. So day by day, the advance in transplant is coming like that. The evolution of transplant is, becoming the bread and butter everywhere. So transplant centers are coming up and patients are becoming aware. So a transplant which was not in reach of many patients who were actually the candidates for transplant, it has become in reach for many of these patients.
Yes, I think that is so rightly mentioned that we have seen diverse conditions being treated successfully, and also previously the access was also limited. Now it has increased gradually, so it is a good initiative. Now moving on to the next crucial aspect, which is donor selections. So what is the current approach to donor selection for allogenic BMT, and can you discuss the role of HLA matching and the increasing use of haploidentical transplants?
Yes, so actually, first, when we select the donor, we have to first go ahead with the HLA typing. So HLA typing is you can say, like many of the patients, they think they come to us, they say, okay, our blood groups are matching, so the matching is there. So we have to tell no, it is not a kind of blood group matching. HLA matching is a kind of cellular type of matching. So we have to look whether HLA matching is there or not. So if there is a 10 by 10 match, we'll have to look at these alleles. So if there is 10 by 10 match, we call it a matched donor transplant. If the matching is usually done with the first, we go ahead with the siblings, the brother and the sisters. So there is 10 by 10 match, we call it a matched sibling donor, as we have got a matched sibling donor. Suppose HLA matching is not there. There is either 9 by 10 match or less than 8 by 10 match. If it is less than 8 by 10 match, we call it a haplotransplant. It is then 9 by 10 match, we call it a mismatched donor. Okay. So when we have first we go ahead with the matching with the sibling. So there's 25% chance that the patient brother and sister will be a matched we'll get a 10 by 10 HLA match with the siblings. So if we do not get a match with the sibling, and if there is a haplo match or there is a mismatch match, we also go ahead with matching with the parents. So parents definitely will always be a haplo match. You know why? Because we have one allele from the mother, one allele from the father. So half match is always going to be there with the parents. Half match can be there with the siblings, half match can be there with the parents. And when there is a half match transplant, we call it a haplotransplant. The third thing that comes into play is matched unrelated donor. So there are some registries, like we have DKMS registry, other registries also, where many volunteers have already given their blood and they have given their consent and given their blood for HLA typing. So whenever a patient requires any donor, they can approach these registries, and these registries will then match the blood or the HLA of this patient with the volunteer donors who have registered on those registries. Suppose we are sitting here and one of the donors sitting in Germany. So there is a patient in India and a donor in Germany, and there is an HLA match between these two. So the advances are so much like that that the donor can actually donate the stem cells in Germany, and those stem cells will be transported via flight to India. And that is how a transplant can be done between a matched unrelated donor. So first, between deciding the donor, we have to decide whether it is a matched donor, unrelated donor, or it is a haplodonor. So first we have decided that. Second thing then we have to go ahead is, suppose we have two matched sibling donors. We have one brother and sister for the patient, and both have actually matched. Then we have to look at the various conditions, whether there are any comorbidities with the donor or not. And always for it is a male to male or male to female transplant, and other factors we have to look when we go for sibling donor transplant. Similarly, when we go for haplotransplant, suppose the two brothers are there and parents are there, they all are haplotransplant. Now we'll have to select between the parents and the two brothers. So 4 donors we have, but we have to select between the 4 donors. So there are some criteria, there are some papers. We have to look at the KIR typing, then we have to look at the blood group, CMV status, and lot number of things. Then we decide which transplant, which donor we'll be taking. Now, when it comes a patient who has a haplodonor also and mud donor also, and then when we decide among whether we have to go for a haplodonor or we have to go for a mud, then we look at the costs involved, how much time will it take for the mud stem cells to reach the patient in where the transplant has to be done. All the factors have to be taken care of when we go ahead for donor selection.
I would say the real advancement has increased and evolved so much in the recent years. Also, it is such great news for so many patients and families at the same time. So now talking about the procedure itself, so could you elaborate on how do you determine the choice of conditioning regimens, and how do you balance between myeloablative and reduced intensity protocols based on patient profiles?
So first, to do when choosing the conditioning regimen, there are many factors we look into consideration. First, which is the disease the patient is suffering from. I'm talking about only allogenic transplant here. Okay, so this the patient is of AML or the patient is of ALL, whether the patient has a CNS disease, in the beginning, or the patient is of aplastic anemia, or the patient is of thalassemia. So depending whether the patient is malignant or non-malignant, which condition we have to look at the disease the patient is having. Then we think about some treatment regimens, conditioning regimens. Okay, this is the regimen we can give to the patient. But secondly, we also have to look at the patient comorbidities. what are the patient lung functioning, the patient liver profile, the patient's previous history of infections, the patient the kidney function test of the patient. We do go for a DTPA. We have to look at the Muga scan, the cardiological status. We have to look at the pulmonary function test. So all these things have to be taken into consideration. The organ profile of the patient has to be taken into consideration before deciding the conditioning regimen. Suppose a patient already had suffered a lot of lung infections and already has some lung fibrosis going on. Okay, and the pulmonary function shows severe restriction. So we cannot go ahead with a conditioning regimen, chemotherapy, which already will have some adverse effect on the lung. Similarly, if the patient has, history of severe liver injury, patient was an alcoholic, is a case of CLD, and we are now, and also suffered from some malignancy, and now we are taking up for transplant. Now we cannot go ahead with the regimens which are prone to cause him VOD. So we have to choose very wisely. We have to look at the comorbidities, the previous history of the patient, before deciding whether we have to go for myeloablative or reduced intensity conditioning regimen. We also have to look at the disease status. What is the disease? What is the disease status? Whether the disease is in first remission, second remission, third remission, whether there was any CNS involvement or not, that will determine whether we need any TBI or not for that patient. So there are a number of factors we determine, and then we discuss, we go ahead with whether the patient needs a myeloablative or a RIG condition.
Mhm. So it sounds like patient safety and treatment effectiveness are balanced in choosing the right conditioning regimen.
Yes.
Now, also with advancement like CAR T cell therapy, I was just curious, how do you see the role of bone marrow transplantation evolving in the management of hematologic cancers?
So yes, CAR T cell therapy is can come like miraculously in the field. So if we look ahead with actually CAR T cell therapy for allogeneic stem cell transplant, especially ALL, is a kind of bridge to therapy. What I perceive it like that is. So there is, patients are refractory to chemotherapy. Now, to take them up for transplant, they should be in remission. We cannot directly take up them for transplant if they have a whole burden of the disease in their body. So CAR T cell therapy helps to bring the patient in disease in remission. And once a patient disease has come in remission through CAR T cell therapy, which is used like after 5 lines of therapy, suppose CAR T cell therapy has been used, and then the patient can be taken up for transplant. So for allogeneic stem cell transplant, CAR T cell therapy is a kind of bridge to transplant. And if we look at autologous stem cell transplant, when we talk how the role is evolving, so in patients like multiple myeloma who have already received an autologous stem cell transplant, which I've already told you is a kind of stem cell rescue therapy, and they have further also relapsed after that. For them, CAR T cell therapy, and they have received also one more line of treatment. For these patients, CAR T cell therapy is the go to. It is evolving, kind of that.
Yeah, I think that is a key point to consider as well. So now, before we wrap up, we'd love to hear about any exciting research or clinical trials that you are following that might, shape the future of bone marrow transplant.
So, at present, there are the research on fecal microbiota transplantation is going on, which I feel is very exciting for me. Why? Because in this is a kind of therapy which is used for to treat GVHD and Clostridium difficile associated diarrhea. So, GVHD post transplant has, if it is not controlled by steroid refractory has a very high mortality. Steroid refractory GVHD at present, in my clinical practice, I have not seen any patient surviving. So the upcoming thing of fecal microbiota transplantation, which has a role to modulate the gut microbiome. The trials are going on for steroid refractory GVHD, and for non-refractory GVHD, it has shown very good results, and also for Clostridium difficile associated diarrhea. So these post-transplant patients, we are very much concerned about the diarrhea for these patients. So this is one of the, I can say, very good trials or research going on at present.
It's been an absolute pleasure having you with us, Doctor. And let me tell you that your insights have been incredible, enlightening for both our audience as well as for me personally. So thank you so much for joining with us today.
Thank you so much.
And thank you to our viewers for joining into this episode of MedSynapse podcast series. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource; it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay aware and take care of your health.